Very good morning to everybody. I'm Dr. Sabyasachi. I'm the Associate Editor of the IJO, and welcome to the IJO session for this year. And it's aptly sort of coined iPitch Innovations in Ophthalmology, because these are innovations in ophthalmology from India. So I'll just quickly introduce you to the session, and then I'll tell you a little bit about the speakers as well. So innovation, the Wikipedia definition of innovation is that it's a modern meaning, in its modern meaning is a new idea, creative thoughts, new imaginations in the form of a device or a method. So in ophthalmology terms, it's almost like a device or a surgical technique. It is something original. But remember that an innovation is different from an invention, and essentially implementation of an invention is what innovation is all about. So from concept to fruition that we are going to talk about, you really have to go through some of these steps. So you have to ideate and initiate, then you have to improve and iterate your your innovations. You must patent it, then you must validate and publish your findings, and of course you need to work with industry and then market it. So we'll take a look at some of these in our lectures. So our faculty are very eminent innovators, they are researchers, they are industry leaders, and their story is truly inspirational, and we hope that we'll learn from their story, and we'll look at their individual story as well as their generalizations about and their thoughts on innovations. So our first speaker will be Dr. Katia. He is from Bhavnagar in Gujarat, and he's the innovator of Omni Glow and many other things that he'll hopefully tell us about, and his talk will be centered on an innovator's mindset. Then we have Dr. Anand Shivraman, who is the CEO of Remedio Innovative Solutions Private Limited, and he is based in Bangalore, Karnataka, and he'll talk to us about frugal innovations, how to initiate and proceed, especially in the developing world scenario. Then we have Dr. Suven Bhattacharjee, who is from Kolkata. We all know him very well. He is the innovator of the BHEX pupil expander and quite a lot of other things. And he'll talk to us on a very important topic of patents, basic overview. Then we have Dr. Rohit Shetty, who is, of course, we all know him. He's from Narayan Netralia. He's a clinician scientist par excellence, and what he'll really talk to us about is validate and publish, which is sort of the new currency for your innovations today. Then I'm from Mumbai. I'll be talking to you a little bit about commercial aspects of clinical research and how you can actually still earn while doing good clinical research. And then we'll have Dr. Nivian Madhivanan, who is from MNI Hospital in Chennai. He's an innovator and a vitreoretinal surgeon, and he'll talk to us a little bit about working with industry. So I call Jagdeep Kakadia sir to start his first talk. Thank you.
नहीं pointer. Okay. Good morning, ma'am, Dr. Subhadra Jalali and Dr. Sabyasachi Sengupta, and good morning, everybody. Innovative mindset is, taking up a chance to bring it to a change. And let me clarify what is the difference between invention versus innovation. So invention is when something which is not existent in nature is invented for the first time. For example, one of our great grandfather must have invented the wheel, but then the journey of that basic wheel to the modern wheel is innovation of the work done by generations of number of people. So to be an inventor is a rare chance. You need an excellent opportunity and the right time and the right luck to be an inventor. But to be an innovator is much easier than to be an inventor, and every one of us can be an innovator in our own right. And for example, Dr. Harold Ridley is the inventor of an intraocular lens, but then the intraocular lens has evolved over a period of time by number of innovators who brought the IOL, basic IOL, to the modern day IOLs. Same way, Dr. Charles Kalman is inventor of the phaco machine, but then the phaco machine has evolved over a period of time because of so many innovations done by so many of innovators. And for an innovator, there is no better slogan than this: arise, awake, and stop not till the goal is achieved. And an innovation can never be brought to a fruition unless there is a team of mindsets which gather together, adding the ideas and making it into a reality. And every problem has a solution. You just have to be creative enough to find it. And as Thomas Alva Edison has said, there is a way to do it better, find it. And my life is my message, as is the 150th birth anniversary of Mahatma Gandhi. So I would just describe some of my innovations in my practice. I made my own excimer laser for the reason that my excimer laser, which I had purchased in 1995, after 5 years it broke down. I had bought it at a crore rupees, and at the end of 5 years, the 45 lakhs loan was still pending, and the repair cost quotation was 46 lakhs. So I decided, let me either scrap the machine. So my wife said, when you are scrapping, why don't you open it up? So I opened up the excimer laser and then studied it and went to several institutes, several scientists, including President APJ Kalam, who was not a president at that time, and made my own excimer laser, not one but two. And something simple can be innovated by any one of us. For example, I have made a frame in which all my foot controls are locked to each other in the reference of my right and left foot. So when I shift myself from right temporal to left temporal, I don't have to fumble with my foot to have the foot pedals of microscope and phaco in the right position. My staff has just to move this, and now we have pinned this to the floor, so they just have to rotate it around that pin. So there are many simple things which we all can do. When I was a resident, there was no microscope in the department. So with Mr. Pratap Jaggi, I designed a microscope which could be clamped to the operation table's side, and we started using that in the department, and we started using intraocular lenses made by Care Group. And that microscope is still date with me, and now we have welded that microscope's pole to the trolley, so the trolley and the microscope is together for all the small procedures, and we are still using it. Now, when I started my practice in 1998, I bought this Carl Zeiss Jena's chair unit, and I realized the benefits of moving instruments to the patient rather than moving patient to each instrument. So taking this idea from this very complicated design, we made a chair unit in Ahmedabad by Plantech Medical System, who were actually dental chair manufacturers. So I brought them into ophthalmology, and we made the India's first chair unit. And unfortunately, at that time, there was no idea to patent it. So later on, so many other companies started making, but I was the person who was the first to make a chair unit in India, and I still have the first chair unit of India still with me since last 31 years. And then this is a Sony's 3D camera having 2 channels. So this camera gave me an idea, and I replaced this camera on a slit lamp. I just removed the slit lamp's old slit lamp's head and put the camera over there and connected it to a large 3D TV. So my assistant, because I have an OPD of 70 to 80 patients every day, so instead of stretching my neck and my eyes in the slit lamp, my assistant examines every patient. I see it on the 3D TV. And whenever I have to do some procedure like removing suture or removing a foreign body, then only I go to the slit lamp. Otherwise, I have 2 assistants who keep on showing me on a 3D TV. So this is my 3D digital slit lamp, which I still use, seeing it only on my monitor and record. And this is Omni Glow, which the name comes from omnipresent red glow. And the story goes that we all know now the advantages of the stereocoaxial red reflex. So I decided to buy a Lumira for myself, but my banker said your balance sheet is too weak to give you a 45 lakhs loan. So then I asked my wife that let us sell your 2 kilograms of gold. Naturally, she would not like that. So she said me, if you could make an excimer laser, why can't you make a Lumira device for yourself? And as Plato has said, necessity is the mother of invention. And then I saw this picture, African boys making their own billiard tables out of mud. So then I decided I would do make Omni Glow Lumera device of myself. So studied Helmholtz's 3 principles of coaxial illumination. Also studied the principle of phase contrast microscopy by Fritz Zernike, because when you increase the glow, the stereopsis decreases and the contrast also decreases. So you have to, along with the glow, increase the contrast also, and you also have to. This is the this is with without contrast and with contrast, tobacco mosaic virus, and this is the paramecium with without contrast and with contrast. So you also have to increase the contrast, and glow and stereopsis again are inversely proportionate to each other. So when you increase the glow, the stereopsis decreases, so you have to increase the stereopsis also. So I studied the optics of stereopsis enhancement and then made a device which would give me a fantastic glow. And with the blessings of my guru Puja Prong Swami and my physics guru Dr. George Beckow, we made we first and Dr. Suvan Bhattacharya, taking some inspiration from him how to go through the patent. So I got it patented, and he is my current guru Mahan Swami, blessing my Omni Glow, and also took help because me and Kalam Sahib Guru Bhai and Modi Sahib also Guru Bhai. So we made Omni Glow which can be attached to any microscope, and as you can see, it's a detachable device which hangs under the microscope. If you want to attach biome in place of it, you can just remove it within a minute, and it gives you excellent ray reflex. In a conventional microscope, there's only one sweet spot where you get the ray reflex, but with Omni Glow you get the ray reflex in any position of the eyeball, in any tilt of the eyeball, any size of the pupil. So about Omni Glow, I think it's a long video, so I'll skip and go to my other innovations. So then after Omni Glow, I realized that if I replace the lights, visible lights, by UV lights, I can create a C3R treatment device myself. So I created a C3R which is otherwise costing 14 lakhs for a cost of 1.5 lakhs, and that 14 lakhs C3R still does not have a microscope. So you, when you're doing it, you need another microscope, and you have to keep on switching between the UV device and the microscope. But here, microscope and UV device both are in the same. And then I realized that if I replace my light source with a femtosecond, small femtosecond laser source, I can do capsulotomy. So I made a device known as IREX, which will give me an excellent capsulotomy. No other, no phagofragmentation not possible, but capsulotomy is the most important femtosecond procedure. So that we made. And then I had a good opportunity to go to Russia and study some time at Fyodorov Institute. This is the office of Dr. Fyodorov at Russian Federation, and had a good chance to work with Dr. Boris Malyugin and his wife Dr. Natalia Maichuk, and we together developed a laser phaco machine. Now this is a phaco machine which is a specific laser which melts the cataract like wax is being melted. So you don't need to hold, you don't need to divide, you don't need to sculpt, no phaco exercises at all. You just keep on melting, and this is just an irrigation device. So there is no vacuum. It is the force of the irrigation which is taking the debris out, and the lower end of this tube is slightly lower than the irrigation, so the fluid goes out just by itself without any vacuum. So this is a fantastic laser cataract extraction which is being developed by me and Dr. Boris Malyugin and the Federal Institute. And then we had a good chance to work with Dr. Shigeru Kineshita, and we took their laboratory research into clinical arena, and we developed eye drops with which you can induce mitotic cell division in the corneal endothelial cells, so that pseudophakic bullous keratopathy and Fuchs dystrophy can be treated medically rather than surgically. So we presented this at last year's Paris ESCRS, where we got the best prize, and also at Kyoto APSCRS, where also we got the best prize for this research. And Dr. Shigeru Kineshita and myself, and we became family friends, so we had a dinner also at his home. And this is the eye drops clearing pseudophakic bullous keratopathy to this clarity. This is the patient, one of the patient who had a CAM surgery, lost the endothelium and went into bullous keratopathy. And on day 13, the cornea started clearing, day 35 more clarity, and day 45th and day 55th, the cornea is completely clear. And Fuchs dystrophy, we observed that not only the cells regenerate, but even the corneal guttatas, they start getting phagocytosed by these drugs somehow. We don't know what is the mechanism, but it works so very well. And then I made a corneal tattooing pen myself. You know, it's such a simple, as if you are making a drawing on cornea. So you can create a very beautiful two-tone cornea. So we made the pupil first, and then with brown pigment, now we are creating a brown iris. If patient has a green iris, you can create a green iris. If patient has a blue iris on the other side, you can create a blue iris. So you know, this is the immediate post-op picture, and this is the post-op picture with two-tone corneal tattooing. So this tattooing pen is so simple that you don't need to be a cornea surgeon to do tattooing. Any of entry segment surgeon can do this. So thank you very much for your patient listening. And there are many more innovations which I have done. So you are all most welcome to come to my hospital at Bhavnagar, and you will be able to see more than 70, 80 different innovations which I have done in my 30 years career in ophthalmology. Thank you so much for your patient listening.
We can only say wow. You know, the sky is the limit. Good. So we now request Dr. Anand Shivaraman to talk about frugal innovations for the developing world, how to initiate and how to proceed. So when we see all this wow, we think, wow, these are people who are super people, but how can ordinary person, you know, develop that mindset and, you know, start the journey? Anand.
Thank you so much, Dr. Shubhadra Jalari. Thank you so much, Dr. Sunny Sengupta. I guess following Dr. Katia, we will be sharing with you a little bit of what we have done. There is, just so that I can be open, there's financial interest in terms of me being the CEO and co-founder of Remedio. What we've been looking at is, as someone who's been in the US and I was working on innovations in the US, what we've been able to see and what I've been personally very thrilled about is really the opportunity to innovate in India in ways that you cannot actually do in the West. And that has to do as a result of both the clinical cohorts in India as well as clinicians in India who are extremely open to dialogue to innovate. And that's a very critical part in which traditional innovation has been, where it's a top-down approach, where you would have something that's designed in the West that then comes to settings which are infrastructure poor. And there is a trickle-down effect. So what we've been able to look at in terms of the past few years is, rather than these force-fit solutions, are there ways by which one can think in terms of simple products that are designed as a result of using the constraints in a developing nation context, such as, let's say, there being lack of access to electricity infrastructure or awareness or skilled manpower, as an opportunity to innovate. It's what we call contextual design or universal design, which then results in products that are so simple that they are actually innovative in their own way and have a global appeal. So just to give you some sense in terms of the first part, which is I think what Dr. Sani wanted me to focus on, which is we use what's called design thinking sprints, which is a way by which you can go from product definition to the final POC validation and then taking it through initial design. So we do a lot of what we call emotive data. So for example, we go observe, and we actually have students from design institutes where there's a cross-functional team that only observes and sees what exactly is being done and where the area of innovation is. And usually when a clinician speaks to us about changes that they would like or something new that they would like to do, we typically observe. So that's the emotive data. And what happens post that is, of course, when we go through the intellectual property to design and the engineering and validation, which eventually leads to the market realization. I would be talking only on the first part because the rest of the speakers will be speaking on the parts on the patent and the commercialization aspects. So just to take you through some examples, this was something that we worked with a non-ophthalmology example, but where we worked with the government of Chhattisgarh, where the idea was for a very simple reason, a simple device for neoliterate health workers to screen for lower respiratory tract infections. So what they would do is just simple counting of breaths, but what we used is get the inputs, worked with them on an iterative basis to come up with certain designs. And this is something that I feel personally a lot about. I feel even those who may be looking at extremely affordable innovations, there's no reason why the device cannot look like something that's designed to have the same feel as what you would with an Apple device. So the idea is always to bring in design and create a center of excellence around design. So what this was a way by which we worked with the health workers within 6 to 8 months, by which they were now able to count breaths and be able to screen for lower RTI pretty easily. Next version of this device is where we've converted it into a pendant that the child, the infant, wears with automatically alarms and beeps when there is a significant increase in the breath count rates. The second was, this was one where in the previous company where we had a problem where CD4 reagents were extremely expensive, 1,000 plus rupees in terms of the cost of a test. And we had brought down the price from 1,000 to around 100 rupees per test. But the key is not in terms of reducing the cost of the reagents themselves, but we were able to do it in a manner where they needed no cold chain, meaning no refrigeration. So I guess the greatest validation is one, of course, when you get the FDA approvals in place, and more importantly, the competitor, in this case, BD Biosciences, then started buying the reagents from us to start supplying globally. So the idea is, again, using the inputs where you can convert the inputs into needs as a result of bringing in clarity on where exactly the differentiation needs to be bought in, and then going through the same design sprint process as a means by which you can engineer, validate, and realize the innovation. The last one that I wanted to discuss about, which is more in the field of ophthalmology, is around 3 years back when we started having a significant number of our funders on phone devices, which is a non-mydriatic imaging system available globally. We worked with a number of artificial intelligence companies, including a group called INAC, Google, where one of the key reasons we realized is the ability to immediately give a report was not there, because the images had to be sent to the cloud and the processing would happen on the cloud and then come back again. So we used that as an opportunity to innovate, and we said, look, is there a way by which the entire AI algorithm can be run on the phone itself? And we had to take into account certain constraints, and this is something that I believe is extremely important. We don't look at the constraints as something which is negative or constraining us in terms of not being able to come out with the product that we have, but use it as an opportunity to innovate. For example, in this case, we found that for mild NPDR, the kappa among ophthalmologists was actually was not very high, including the case where we would have medical retina and vitreoretinal specialists. So what we did was we trained the algorithm only on no DR to increase specificity of no DR, and RDR, or referable DR, to increase sensitivity of RDR. And the idea was, how do you still keep it at less than $1 or 50 rupees a report? And so what it resulted in is a patent that we got in terms of how you would do this on the phone itself, which we then clinically validated and brought to market. But again, the idea here is to say that there are certain things that I think we are able to do in India, primarily because we are in India. Because the constraints force you to think in terms of solutions that I believe is going to be difficult for either an academic institution or a company outside India to think the same way, primarily as a result of the fact that the constraints force you to innovate, and you do have clinical cohorts and clinicians who are really interested in being able to work with you as a population. I think that's extremely important. We'll leave you in the last slide in terms of key lessons learned. Time spent on articulating and validating the need to be addressed, I think, both from a technical and business perspective, is extremely critical. As I mentioned, defining the constraints of product use in India forces innovation. This is one thing that we've learned, especially when you go outside India in terms of selling the same product. We made the mistake of focusing too much on affordability and focusing too much on the fact that it's low cost. But I think it's really the fact that in addition to cost, if there is something else that you're doing new, I think that really has a global appeal. For example, we realized that the same product that we made in India, we reduced the weight of it and it sold significantly in the US, but it's sold as a result of the fact that it's the only non-mydriatic device available on a smartphone. So I do believe that low cost is extremely important, and by doing it in India, it naturally will be low cost, but being able to have an additional feature that is new or novel, not available in any other product, is extremely critical. The second is patents and peer-reviewed publications in today's world is the currency for global product acceptance. I do know that we were struggling with sales outside India, but as soon as we started having a significant number of publications coming out, it changed significantly in terms of the acceptance of the product in the West as well. So to a certain extent, the currency is about peer-reviewed publications as well as patents. And finally, and this is what I'm extremely excited about every day in India, is the fact that it's possible to have a cross-functional team that's also made up of clinicians who are ready to take up the time to be able to work with a young group of engineers as well as product developers. And I think this is something that is possible, at least I can say, with having worked in the US and built some products there as well, is only possible in India because of the fact that we get access to clinicians much easily and actually involve them as part of the product development process. So these are some of the key lessons learned in going from need to the initial validation to bringing it to market. So I'll leave it with that. Happy to take any questions, but thank you so much.
Any questions on this? Thank you so much. No questions? We'll move on to the next and a very important talk on patents by Suven Bhattacharya. Suven is an innovator who has commercialized this product very successfully.
Thank you, Santosh. Thank you, IJO, Subhadra ma'am, and Sunny or Sabyasachi. Many wouldn't know him. Thank you for this opportunity. And what's happened? Why isn't it coming up? Yeah. So I'll try to keep this very simple. The idea is to initiate you into the process of patenting. So I guess all of us who are in this room have had a great idea at some point or the other. So that's the reason we are over here. So I am an eye surgeon, inventor, entrepreneur, and of course I have a financial interest in terms of my holdings in MedInvent Devices Private Limited. So the idea is whether you invent, patent, or commercialize, the patent is the heart of the invention. So why do we talk about this to doctors? We are always full of good ideas, but most of us are unaware of the process to take it to fruition. And the most important thing is it is believed that it is unholy and sinful for doctors to earn from anything other than patient care. You can be racing horses, you can be gambling, you can be doing everything else, but when you invent a device and you want to commercialize and earn from it, it is unholy. Doctor kyun paise banayega? Okay, so let's get out of the mindset. Let's educate ourselves, let's educate our colleagues. So there are a few standard checks once you have a great idea. Is it a great idea? What kind of great idea? And what to do, how to do, and when to do. Once you break it down into these simple 5 steps or standard checks, you will have a more organized approach to your work. So the first thing, what would you do when you have a great idea? Can any of the young people over here tell us, what would you do? You'd probably go and tell your friends, your boss, you want to impress him, get some brownie points. Well, that's what we do. And that's exactly what you're not supposed to do. Okay, so you have to curb your enthusiasm. Don't discuss, don't present, don't publish to start with. Hold it, hold your guns. It's confidential, it's top secret. Get it somewhere and then start talking about it. Otherwise, you'll have that look on your face. Right? So, more importantly, you published it, you thought you'd get in a good peer review journal, and well, you got publication, fine, you got its index journal, and you got citations and everything, but then it's not patentable because it comes into the domain of prior art. It's already been visible to the world, so it's always there. So when you go to file your patent, if this thing is predated, then you really don't have a claim to it, irrespective of whether you have published or somebody else has published. So there are 3 important guidelines. Talk intelligently, deal methodically, and work diligently, because our time and resources are very precious. So, is it really a great idea? You need to be ruthlessly critical. Save yourselves time and energy, money, emotion. You can think that you have a brilliant idea, spend lots of money on it, and then you'll realize that somebody has done some version of it, has already published a patent, or it's got dumped, whatever it is, and then you lose entire thing. You make a total fool of yourself. It's emotionally draining. So the three sets that you need to fill is it desirable to users? What is possible, feasible in technology, by technology? Is it viable in the marketplace? If you have checked these three boxes, then you have an innovation in place, and then it's worth proceeding with the next steps. So, is it a new great idea? It's a great idea, but is it a new great idea? Only then we are talking of patenting. Otherwise, it's just a great idea. So, we don't want to, like we all said, we don't want to reinvent the wheel. So, how do you find out whether it's a new great idea or not? There is patent literature freely available. You don't need a lawyer to start with. You can go on to a patent agent or a lawyer, you can do that. But then you don't need that to start with. You got Google patent, you got WIPO, World Intellectual Property Organization, USPTO, the INPASS. These are all free searches, and you can really get a good hang of whether your idea is really good or not. So you can look at granted, not granted, pending, abandoned, whatever, however way, there are different ways of searching. Look at non-patented literature. Non-patented literature also becomes prior art. Whether it's patented or not, it does not make it prior art. So when you say prior art, that means it's been there in the public domain before. So when you do a Google search, you must include non-patented literature. Then you get all kinds of literature that is there. You can do that in WIPO also. You can do that in USPTO. And in fact, the USPTO has a web-based tutorial which teaches you and takes you through a hand-holding course. It's about 38 minutes. And this INPASS is also fairly good in about this Indian search system. Now you have a great idea, but is it technically feasible? If you have a great idea and you want it to be meaningful, it has to be commercialized. If it's not going to be commercialized, it's not going to be used, well, then you've not really achieved the ends that you started with. So you need to look at the technical feasibility, and current technology must be able to commercially produce it in a consistent, safe, and cost-effective way. Prototypes can be expensive. Anand will tell you all about that. Prototypes can be very expensive. We all deal with it. But then you have to know that, okay, commercially when I'm going to do this, in bulk production, the costs will come down. If viable in marketplace, now you look at it, whether it's patentable. So the best invention actually is something which you can commercialize anyway. Patent or no patent. Paisa to wapas aa jayega. So that's one thing. You will recover your costs, at least at the first mover advantage, and you recover your costs. Then you can think of patents and then building on that. That's bonus, right? So what is a patentable invention? This is the heart of this entire talk. Novelty. It must not be known to the world. And when it comes to novelty, there should be non-obviousness or an inventive step which is not obvious. I'll talk about this because we define often when I talk to our colleagues, we say, Mera invention hai, sir, this is an invention. Then I have to, kind of break down and say, okay, what exactly is your invention? What is it new that you do? Then we start fumbling and we really don't get a handle on what we want to do. So when you are filing a patent, you must be very clear when you're talking to your patent attorney or whatever you're doing. In fact, actually, I did most of it myself, so I have a very good idea. I had to go through a lot of trouble, but, well, so you must know, because otherwise your claims will straight away be rejected and you wasted a lot of money. So there has to be an inventive step which is not obvious to a person skilled in the art. So you invent something, and if it was very obvious to me, it's still not an invention. It may be new, but it was very obvious it's not an invention. Okay? So utility, it should be of industrial applicability and enablement. Others should be able to make it. You just can't have something as a figment of imagination and this thing. So now let's look at just my personal example. I have only one invention, so one invention which has gone forward. There are a lot of others which have got dumped. So let's say if you want to differentiate between the Malugin ring and the B hex, What's the inventive step, the novelty? The novelty is that the device is in single plane, that's one part, and the fact that the pupil margin now straddles the notches. In the Malugin ring, the device straddles the pupil margin. Here, my notch is like this, and the pupil margin goes like this. That is the inventive step. So you will have to break it down to that objective point, and then you get an invention. So, like I said, what kind of great idea? So what is patentable? This is pretty interesting. So existing structure is not an invention. A process technique is not an invention in India. In US it is. A new application of an existing device is again not an invention. So publish, get your brownie points, get your citations, you're done with it. New device design with utility. Variation without novelty and inventive step, publish videos, do whatever you want to do. Not patentable. De novo, with novelty and inventive step. That's important. Or a variation with novelty and inventive step, now consider patenting. So if you have come down all this way, you've excluded everything, now it's worth patenting. So how, when, let's say you had a good idea, you don't want to spend time, effort, and money. That's quite possible. You can say, okay, I got a good idea, I just want to palm it off. I don't want to earn, but let's just get a bit of credit out of this, that's fine. So you don't want financial gains. That's good. Or you want financial gains. Be very clear about that. Can't be halfway, So if you don't want financial gains, publish as early as possible, get credit, done with it. You want financial gains, then you'll have to keep that idea to yourself and nurture it and take it to a marketable position, a tradable area where somebody is going to pick that bait and spend on it and then give you revenue or you earn revenue. So you discuss with industry. Now at least you must sign a non-disclosure agreement. I just got a call from one of our colleagues. The first thing I told him, don't speak to me, you first file a non-disclosure agreement, not with me, but with whoever you discuss, because I'll be telling you only broad guidelines. I don't want to know about your invention. So the problem is you may get a raw deal or no credit, because the industry has different ways of going about patent and then conning you into it. So it may be stolen completely. That's the risk you run. Well, that's your choice because you didn't patent. Now, if you want to bring it to fruition and succeed, irrespective of financial gains, you have a limited will to spend time, effort, and money, secure the idea, file a patent. You just can file a provisional patent or with complete specifications. You have your claims in place. So now you have what we call a currency or an instrument to trade. A patent is basically an instrument to trade. Okay? So then you start pitching to the industry. Then the industry will look into it. Okay, how good is this stuff? They will have their own lawyers to look into this and say, okay, yes, no, we've already got this and this is not worth it. It's not going to do the market. They'll do a market survey and see what's the demand, whether it's desirable, feasible, and all. And then they'll come back. They either handhold with you and take you further, or they buy it out from you, whatever they do. If you can spend time, effort, but not money, then you file a patent, prove the concept, and apply for a grant, get insight, mentoring, networking. There's a lot of resources and pretty easily available and at no cost practically. You pitch to investors. Then that means you're willing to share your earnings. At what point you want to dilute your equity is up to you. Now, if you're willing to do whatever it takes to bring it to fruition, someone like me, crazy like me, well, you have to become an inventor, entrepreneur. You have to be bitten by the bug. Okay? So that is, preparing a patent application is no big deal. We've all done our research, we've done our thesis, we've done a paper publications, just simple review of literature, description, drawings, and then claims. Claims have a structure, just like our abstracts, papers have structure. It's not rocket science. It's not rocket science. The patent lawyer will make it feel like as if it's rocket science, but they are most often a little more dumb than, rather, I would not use the word dumb. Okay, they're less knowledgeable than you are because it's your subject. It's the only thing you have to give it to them in a well-packaged manner so that they can take it forward. So patent filing fees is not big deal. It's just about $1,600, $1,750, depends upon what status or online or whatever you're doing. Patent attorney fees is very expensive. That you can negotiate. Patent prosecution can be very expensive going further. In India it's not big deal, but when you go overseas, it's very expensive. I have, don't ask me how much I've spent. Okay. The process is long and arduous, anything from 3 to 5 years. Expect objections and rejections at every point. Every country does not want to give a patent. Is country based. Patent is, there's nothing called an international patent. Patent is country based. No country wants to give you a patent to start with. So your first application will get rejected when you go there. Do I have enough time? Yeah. So patent filing in India is, forget that big matrix over there. The whole idea was to show is you can do a provisional application and secure your idea. And then you have 12 months, 12 long months to sit on that idea, chew on that idea, talk to people, do your prototyping, see how well it's going. And you have 12 months actually to now do the spending and do whatever you want. So you have a long time to file your claims. So you have your drawing and description in place, then you can go ahead and do your claims. That comes later. You can't deviate too much from your original filing, but yes, so this is the process of filing. If you file in locally, and then you have to go, if you what you call the Patent Cooperation Treaty, the PCT, it gives you access to 153 countries. All that I'm saying is all available online and very easy to read. So, and you gives you another 2.5 years to think and decide how far you want to take this. That's very important. 30 months you get. So let's say at 0 you start, you file a patent, you have 12 months now to file your complete, let's say in India you file, and you have 12 months to file your complete specifications, or what we call the claims, okay? And within this 12 months also you have to file your PCT application. Now once that's done, at the 16th month, now in this is typical, now each country has its own patent office and you can do that. And when you file a PCT application, what you want to do is you have to choose a ISA, International Searching Authority. Fortunately, we have one in India now. It's not very expensive. When I filed, it was not there, so we had to go to the European Searching Authority. So the ISA decides. Now ISA, what they do is, it's a kind of common hub which now decides whether you're patentable or not. So it'll do a search and give you what is called a written opinion. Okay, and there is an international search report and a written opinion which comes at 16 months, and then you have another 2 months to change your claims if you want to. It really doesn't matter, because that you can keep changing further. And then you have at 18 months you have what is called an international publication. So that is a written opinion. If it goes in your favor, damn good. You have really made it, you have killed it. Because then you can take that, that's your negotiating tool, you can take that to company and start saying, okay, I've got a written opinion which is in my favor, the international search report is in my favor, and this is halfway done. Okay, so then you have another few months, that is still 30 months, most countries, and 30 months, then you have to enter what is called the national phase. That's where the big bump is and the expenses skyrocket. Because then it's going to be in not 1, 5, 6, 8, 10, 12 lakhs per country. Okay, so you're really going to pay through your nose. Be prepared for that. But then by that time you have an idea whether it's going to fetch that kind of money or not. So you have 30 months or 2.5 years. Now that's how a patent application looks. That's the US patent application that we have, and that's the Indian patent application. That's the US patent certificate. Certificate looks slightly different, but and this is the Indian patent certificate. And this is what it really carries. It gives you a patent number, the inventor, and who holds the patent, who's the owner of it, maybe a company or an individual. And this is the list of issued patents that we have in 17 countries. So you know how much I have doled out. And I got no support, so this is all from my own pocket. That's why I don't have a hospital or a great clinic. So what I'm trying to say is commercialization of a medical technology, success in science and success in business are two very different skill sets. All of us may not possess it. We can learn. We are learning every day. We're not good businessmen sometimes. Some are. But well, the bottom line is, if you have a customer desirability, technical feasibility, and a business viability, you have an innovation. You must work on it. Think big. Start small, act fast. Thank you. I'll be leaving shortly because I've got a flight to catch, but I'll be happy to answer any questions now or later. You can just get in touch with me. I'm very accessible. Yeah, ma'am, you want to say something?
No, I'm just seeing there's no email there.
Oh, suvenb@gmail.com.
Thank you, Dr. Suven. That was really enlightening and path less trodden. So thank you so much. So I'll now invite Dr. Rohit Shetty to talk to us a little bit about clinical research to validate and publish your innovations. Anand has already told us that patents and publications are the new currency, isn't it, to popularize what you're doing. So we already heard about patents. Now we'll hear about how to publish your innovation.
Thank you, Dr. Sunny. I'm going to speak on clinical research to validate and publish your innovations. These are my financial interests. I don't expect to have this impact in any of my talks here. So innovation and clinical research are not easy. Requires novelty to stand out, because I think that's what the previous two speakers have already explained about. The two questions which comes to our mind when we want to do something to do with innovation, whether it's related to research or to publish. One is, can I? This is your angels talking to you, and demons in your mind, which is sometimes the predominant speakers, which keeps telling you why, because they don't need to do it. The most important thing is, I think Dr. Suven also mentioned about this, is there is most of the work has already been done, because there are thousands and thousands of researchers who are already working on something. So questioning what if should be a very, very strong question. Me and Dr. Suven were co-chairing the Rangachari Awards yesterday. Little disappointment, because out of the 19 papers, only 4 had, one is a winner here, only 4 had a research question which was worth looking from the second slide onwards. The rest of them had no research questions. Unfortunately, I mean, I'm very passionate about AIOS, the whole Rangachari stuff and all that. So I find it quite, I sometimes get very angry when somebody has come so far without a research question. So I feel research question is the most important thing, because that's the question which we answer. Sometimes the research questions can be extremely crazy, because that's a fear I think we have. 99% of our research questions get shot down because your colleague who's sitting next to you, who has no idea about it, just says that it's too crazy, and just people are going to laugh at it. Like, for example, Dr. Pukrash's paper yesterday was finding a biomarker in urine for something for the RMD. So it looks completely crazy. So exactly what we did was, we were looking at psychological factors in outcome of surgeries. It looks very crazy. These are all crazy ideas which you need to plug in, because that's the area which there are lots of areas where we can try to publish. We had to mingle with people who don't speak the same language. That's what the winner yesterday was. That's what I keep saying, that if you keep talking to the same people, you'll get the same kind of run-over-the-mill work, and you will probably never reach anywhere. You can't patent it, you don't publish it. I think Dr. Honavar sir must be getting lots of these papers, which is the same copy of, like, for example, South Indian, 200 eyes of South Indian eyes, 200 eyes of East India, 200 eyes of something. That doesn't work anywhere, because it's in India. If you are looking at two geographical population, African Americans versus Asian Caucasians, that is a different this is the different thing. I use this a lot in my presentation. I call it the drop the story, because all of us have a predetermined idea about how things should be. And that's why it's very difficult today to publish a novel work, because we don't want to come out of the story. We have somebody, it's written in the book, I'll go to exactly to do the same thing, maybe add a little bit more. My p-value is a little bit better than hers p-value, and that's it, that's how it is. So the story, dropping the story, is the most important thing in your clinical research. There are different ways to do it. I'll not go too deep into it, the preclinical, the clinical, and the analysis part of it. I'll give you some example. When we had this curiosity, why some patients who have neuropathic pain are not responding. So we started seeing a small trend that these patients were patients who had with severe vitamin B12 deficiency. So we Googled it at that point of time, not Google PubMed. There was nothing on vitamin B12 in the eye. And we started writing this report, and this was hypothesis. That was not clear, but fortunately we got a good reviewer. He explained he wanted to create a hypothesis and clearly write that there is an hypothesis, because it's very difficult to test it on a case report. And this was the first case report on vitamin B12 and ocular neuropathic pain, which people said that vitamin B12 have known. This is the first entry into nutrition. So what was important is when you get a lead that there is a nutritional deficiencies which has not been studied too much, you start working on this direction, these directions. For example, after this, we started looking at vitamin D in the eye, and these are all the papers, maybe around 20 papers on vitamin D and eye itself. And I'm not quoting the papers on ROP, Anand has worked, and some retina, but you can see how it started with just a clinical observation. This is very important. You start with clinical observation, give hypothesis, you'll be rejected if your hypothesis is not strong enough. For example, if you really look at this here, the hypothesis has to be really strong enough from your published work from different zones. It need not be ophthalmology. This is from brain, this is from muscular peripheral neuropathies. We use all kinds of concept to come to the eye and build it. That's very important. And then the vitamin B12, vitamin D happened, and you can see that finally, after say 8 years of working on that project, we came out with this paper in IOVS as it's one of the largest vitamin D related work on that subject. So that means starting with the case report 7-8 years back, kept jumping to 20 papers and keep publishing on that zone. People will start realizing that you are a kind of a small authority on it. And journals also know, I'm sure sir would know that he will also see if somebody has published on something which is unique, he will know that that person, if you PubMed him and you know that his papers are all on that easy. This paper completely, that's why there's a lot of my ex-fellows and colleagues who started with me 8 years back. That's something which is important. Just because somebody does not work with you at that point of time, you have to acknowledge somebody who worked with me 8 years back, somebody who worked with me 9 years. So I keep a documentation of who started that work, and irrespective of where they are, I keep entering them. And the first author is not even me, it would be somebody else. So what I'm trying to say is that give equal representation to everybody who's worked in your journey of some papers. So you have to be very, very good with this. This is for sir, and we have to have mercy on when we publish papers, something to do with biology, because we cannot get statistical significance. Biology is very difficult. Dr. Pukhraj's paper also, it's a trend, but you can't get a significance. I know it's difficult for journals to accept something where is a trend, but that's how biology is, and that is where I think we are going to have any issues. How much time do I have? Okay, I'll just give you some papers which were submitted yesterday for the AIOS. Sometimes when you submit this paper, these are too early phase, but if you keep working, you'll see something like that what I just showed. Dr. Gairek worked on AI. Why AI is important? This is what the research question is. Can AI help in predicting keratoconus? This is his first slide. I'm just taking his slides. And look at the conclusion. And this is the methodology, how AI is worked on the corneal diseases. And he looked at the complete new parameters. This is what is the most important thing when you are publishing today. What was known in literature, what does this study add? So at one shot, you know that this study adds a new trend, a new classification, a new keratometry which can combine. So that's it. That's how it is. And no journal is going to take this off if you're not going to publish this. The second paper on unusual bacteria. That means what was a research question asked by her? We all know about this. If normally the trend is that we all start studying the same thing because it's easy. But what was studied is, can bacteria be driving force? Because in the era of coronavirus and microbiome, so she did a genetic genomic sequencing, and you find, and this is what was known, and what does this study add? Adds that it is a completely new microbiome which could be driving. So how does it work? This microbiome can be titrated tomorrow. Point of care diagnostic is something similar to Dr. Pukhraj. This is a kit which looks at how does it work, how does the kit work. It can help to titrate what drops you're going to use. These are all some questions, and what is the process? I mean, this is very important when you build a kit. Where are we now? We are here now. What is the next step? Sensitivity, commercial, and lab production. So every single thing has to be by a flow. If you don't have a flow, what happens is we don't know where it is. Somebody comes and says, I'm going to do this in the lab. He may be just here. We think that is already coming to the clinic. So if you don't put a block where we are and a timeline, this works. And I mean, sometimes, I mean, these papers were severely criticized also in this AIOS, and none of them reached anywhere, not even the first step they won, because they think that this is not necessary to a country. I mean, that's what I said, you know, sometimes these ideas look crazy, but you need it. They said microbiome does not cost anything, but if you just go out of ophthalmology, 80% of the disease in other than ophthalmologists believe that microbiome runs your body. Finally, what really drives is a constant curiosity, the inner fear, the demons. Like I keep telling my fellows, all these papers did not go through anywhere. So I said that if you feel that you are worthless, they'll not work, because somewhere it will be respected. And strong research methodology is important. Like I said, exactly the flow, the research question and what it's going to lead. Collect and store everything possible. That's your biomarkers work. You have to work with people who are not speaking the same language like we all do in this room. That's not the comfort zone. I work with Anand. The kit, he has helped tremendously in working on the kit, and very fortunate that he's been part of our journey with both the Remedio and fundus camera and this one. And please collaborate, and like Suven said, whatever ideas you want, you decide whether you want to commercialize it or you want to publish it. If you want to commercialize it, patent it, look at the commercial angle. Otherwise, just work on the science like we're doing today. Thank you.
Thanks, Rohit. I think that's wonderful thought process. Now we'll move on to the next paper. The presenter 6 is not here, so Sabyasachi will speak on the commercial aspects of innovations and clinical research. He's from Mumbai and he's going to talk to us on the
Thank you so much.
commercial. Meanwhile, if there are any questions, please write them down or you can pass them on.
Thank you so much, Shubhadra ma'am. So, I thought Dr. Shuven has already, set the tone and said then, why should a clinician not earn from some of the innovations or some of the clinical research that you're doing? So what I thought is, finally, sometimes, not always, but the bottom line is, is the revenue that you're making in a year, your loans, and like Dr. Katia told us, that his exam machine broke down even before half of his loan was through. So are there legitimate ways to earn by doing some good clinical research is something that I thought I'll talk to you about. So this is basically what you're trying to say. Can you earn legitimately by doing good clinical research? Expert tips I wish I knew. This is always in retrospect. When starting research, sometimes we are late. We are not really taught a lot of these things during our residency. So, how do you be a good researcher? Because clinical practice is more lucrative, and acquiring strong fundamentals in clinical research techniques is critical right from the beginning. So during residency is something that we need to inculcate a lot of these habits. Build up your research skills from residency days. So I'm reiterating this, but however, it's never too late to start. So, to be good at what you really need to, sort of break it down, as you've been hearing from a lot of the speakers before, is you need to be good at literature review, some basics of biostatistics, communicating with a biostatistician, some, basic skills of manuscript writing, and then you have to understand how to deal with rejections. But the problem is we've never been taught this before. And, really we really never have been taught this before. So we are all trying to learn bits and pieces when we are out, assuming that we have become good at clinical research over a period of time. So what you can really do to make legitimately can earn more from this. So this is a summary slide. We'll take a look at a little bit of each of these. So what you can really do is write research grants and funding. You can be part of multicentric clinical trials and participate where there is remuneration for those. You can be a research consultant, speaker, or advisory to the pharma world. You can serve as an expert for market surveys. You can collaborate with academia. You can offer research related services to other physicians. You can act as an expert panel for many government and sometimes international agencies. You can review papers and earn these days, and you can assist venture capital firms in analyzing some proposals. So I'll share a little bit of my experiences with each of these. So research grants and funding, so the notion or the concept that it's impossible to get is wrong. So I'm sure a lot of you have not even tried to write up a research proposal, but we have people from Shankar Netralaya, we have people from Narayan Netralaya. So there are a lot of projects which are funded by ICMR and a lot of international agencies which are going on in these institutions. But at your own level, you can also do these. So you can look up these. So the ICMR has something called extramural grants. DBT DST also has many small grants which are on a recurring basis, which you can look at. And there is I hope that you will take a look at this website. It's called TrialEct. So this is an agency which alerts you about grants as well as about international fellowships. So this is a screenshot of the ICMR Extramural Grant Research Program. So it's easily available on Google. You can look up. So there are grants available from 1 to 5 lakhs on a recurring basis. So this is the TrialEct website that I was talking about. So it talks a lot about get started, active opportunities. You can also host a trainee if you want. So please take a look at TrialEct and register. Then multi-center clinical trial participation is getting more and more lucrative nowadays. So because all ingredients for large randomized clinical trials to evaluate new drugs and devices are really present in India, isn't it? What you really need is patients, good doctors, regulations in place, clinical research organizations. So global pharma recognizes this. Institutions like Johns Hopkins have India offices in Delhi and Pune now. So they are big time into tuberculosis and HIV drug research in India. Many institutions are already part of global clinical trials, and there is remuneration offered for your participation. This is just a screenshot of one of the clinical trials on which is a phase 4 clinical trial on use of Lucentis world over, and you can see India has contributed some patients. So there are already physicians amongst us who are part of these international groups. Then you can be consultant to speaker, consultants or speakers or advisory to pharma. This is highly prevalent in the Western world, like we already know. So research-oriented clinicians are paid very well in the capacity as speakers, advisors, and consultants. Many physicians also hold equity in some of the upcoming companies. So this is a recent example of a Harvard professor of medicine who has made a whopping $400 million as part of a biotech company's initial public offering. So Indian pharma is slowly rising up to this. They realize that physician inputs can help in many areas, including specific product inputs, sales strategies, and doctor interactions. And if you are an established researcher, you can serve as an advisor and look forward to earning from this source. And then you can serve as an expert in market surveys. So what are these market surveys? Are basically before launching a new drug, instrument, or blades, intraocular lenses, and any of these, most companies think about a market survey. It's almost like a feasibility study for them. Surveys try to understand how these may be received and identify pain points for the end users. Surveys usually target the top brass in a particular field, and you want to be part of that. So a strong research-based LinkedIn profile is a good initiation point. And you can enroll your name in databases such as Marvin. This is the website. Like I showed you, TrialEct. This is also something that you probably should enroll yourselves in. Then you can serve as an expert in market surveys. Simple questions. They can range from which kind of logo do you prefer, to costing of the product, to how you perceive latest medical evidence of this efficacy, how likely are you to adopt it in your own practice. All the top surveys pay very well for your time and efforts. So they are conducted by very large agencies such as Ernst & Young, etc. So I was part of a market survey which was done by Ernst & Young, and it was on design of a new intraocular lens. The collaborate with other academia is something which you can also think about. It is immensely pleasurable and and such a great experience to interact with academia in other fields such as finance, market research, health tech research, etc. So my personal experience has been I've been involved with the NMIMS. That's a top B school in India, and what we did is I helped them with design a market survey to find out how physicians would respond if medical representatives are replaced by digital marketing strategies. So these medical reps come and tell us, write my product. But what if they were completely taken out and you received all of that digitally? How would you react? So I sat through a series of meetings, contributed, earned, learned a lot, and sort of earned a bit too. It's all relative, but still you can earn some doing that. Then you can offer your services to other physicians. Publication assistance for a fee is coming in big time into medicine now. It's very valuable if you can deliver high quality manuscripts consistently, and there is an increasing demand for publishing in the medical world these days. And so this is my endeavor into this. So I run Sengupta's Research Academy, where I offer some research and publication assistance. Then you can be part of expert panels for agencies, say expert panels by governmental and non-governmental agencies who are actually planning an implementation of schemes. So, grant commission invitations. So my personal experience has been, I've been part of the review boards for the Hong Kong Research, Grant Council, which is the equivalent of an ICMR since 2015, and there is some good remuneration for these. Then you can actually review papers and earn, where nowadays there are many open access journals who want credibility, who don't want to be seen as predatory. So you can look up what a predatory journal means. So these open access journals are basically ones where you can read articles for free. So what they're doing to get credibility is they're outsourcing manuscript review, who want quality and rapidity of review. So many agencies are doing this. They pay about $50 to $100 per paper. Say if you review say even 5 or 7 papers in a month, it's a good financial remuneration. And the website is called Research Square. I haven't put it up here, but if you want, you can actually go and enroll and you can upload your CV. And finally, what you can do is, assist venture capital firms. There is tremendous interest in Indian health tech startup companies. Government is also investing a lot into all of these. And there are, large venture capital firms such as Sequoia Capital or Nexus Ventures. So these are, companies which have invested more than $5 billion into India already, and they are heavily investing in health tech startups. So there are some which do this as a niche only for medical health tech. And before investing in millions into these venture capital firms, they want a good idea of how strong this startup idea is. So that's basically called vetting. So your research is a particular field, makes you a subject expert, and proposals will come your way to scrutinize these. So I have been involved with Nexus Ventures in 2 or 3 different vetting processes. It's extremely, it is really rigorous, and you have a 40-page questionnaire really to fill out. But then they actually pay you quite well. So in summary, so if you are good at clinical research, innovations, and publishing, what you can earn legitimately is through research grants and funding, multi-center clinical trial participation. You can be a research consultant, speaker, advisory, and serve as an expert in market surveys, collaborate with other academia, outside medicine, offer research-related services to other physicians, act as an expert, review papers and earn, and then also assist venture capital firms. So you really become you become like a magnet, and then you start getting a lot of different opportunities. So the word earn is part of the word learn. So so this is still from one of the movies which says, "Bachcha kabil bano kabil, kamyabi piche bhagegi." So get out of the comfort zone. The magic happens outside the comfort zone, and so try and be good at research and publications. Take home message is earn, enjoy clinical research, learn, and then earn by doing it. Thank you.
Thank you, Sunny. Any questions to Sunny?
So I just had one question. So how do you balance any conflict of interest? Because you're getting all these things from various areas, and there could be conflict of interest, or what you recommend for one versus the other. So are there things that you have to say, no, I can't do this because I'm already doing something?
Very much. So ma'am, first thing is that, I think the transparency is very important. So I would recommend everyone who think that they have or may have a conflict of interest to declare it first. And sometimes you may not be in a position to decide, because the person who is sort of employing you, or the person who is actually paying for those services, may then say, this is too much of conflict. So there is always a gray zone between what is too much conflict and what is too little conflict. But I think it's very important on our part to declare that conflict of interest. I think that is important.
Thank you so much. The next speaker is Nivian Madhivanan, speaking on working with industry to bring innovations to the market.
Thank you, sir. So, respected teachers, senior ophthalmologists, my dear friends. So, I'm going to talk only on the innovation that you have, how you work with the manufacturers, because my previous speakers have already gone through the rest of the things very much in detail. So, before I start, I don't have any financial interest as of right now. So, to bring the innovation to the market, first thing this thing was you should get inspired. You should want to do something more. So that's what I think all the previous speakers done. So this is how I got inspired. I think Dr. Ringlingam Gopal is not here, so he was my mentor in VR surgery. I think Pukraj Rishi sir is there. And today morning, just half an hour back, I was listening to Dr. Jagdeep for the first time, and I've become a big fan because he's got 40 innovations, and I'm here standing with my first one trying to deliver a talk. So he's really a big fan moment today. And Rohit Shetty, yes, I saw him 8 years back when he spoke about basic research. And that time, I don't think so many of us sitting here would have agreed that talking about basic research is going to get somewhere. But now, after 8 years, the entire world is working on biomarkers and how the keratoconus thing is revolutionized. So these are small things that you take and then get inspired. Then Suben, yes, I had once breakfast with him, and that is when he told me the entire thing that you all heard today. And he's a very hard worker because he manufactured his own BX ring. So that's why I'm different here, because he said he set up a lab in his house. He's got a physics lab, chemistry lab, and then every day at night he used to go to his basement and then do all the materials and testing. I think that part he didn't show you the pictures. So that is how he did it every day in his own lab, and he buys all the things that are needed for doing he found out the material that is the BX is used for. And then Dr. Rangaraj Venkatesh sir is not here from Aravind. So he's my teacher and also a critic, because you need these critics to actually tell you in your face that this is right, this is not right, this could be better. And that actually lets you modify and takes you to better places. I think Dr. Santosh Honavar, I have a close relationship with oculoplasty because my wife is oculoplasty, but I don't watch her videos or assist her surgeries, but she's a very big fan of sir's. And what sir did was bring 3D, I think everybody's seen, but to bring it to a teaching module and then bring it with the 3D projectors and then teach, that was something great. And that was really, so I sat through one of my first oculoplasty courses. His surgeries are amazing. What I learned from it was totally bloodless, so I haven't seen oculoplasty surgeries like that. Thank you, sir. And Sen Gupta is a good friend. That's it. Because you need a good friend in the end of the day to bring out all these things. So getting to the point, so idea, yes, you should always ask the question why. And that's how I started as a VR surgeon. So we've been doing a lot of secondary IOLs, and it's like SFIOL has been there for a long time, and then you see modifications like the glued IOL. Now it's almost completed a decade. Then you have the XNIC technique that was done by Aravind Eye Hospital, where you are externalizing the haptics using these needles. And then you had the MNA technique that has been used now, in which they do a cautery. So what came to my mind was like these were all existing IOLs and different techniques that they're using with the existing IOLs. So that's where I wanted to know whether we can have a design of an IOL that could be different. And before I go further, I'll say this idea was almost 2 years back. I know right now, like I think Suman sir already told that other researchers, because everybody thinks differently in different parts of the world. It's not that you're the only one and this is my design. It's not like that. So I also had this concept long back, and that's how the whole basic drawing started a year back. So because it is an IOL, you need a manufacturer. So that is why my talk comes into play. Because I cannot, unless you own your own factory, that's a different story. Otherwise, you have to work. And since I'm from the south in Chennai, so I have limited option, and I chose Appasamy. Either you can choose financially or whomever you're comfortable. I was more comfortable with them. That is also very important in the initial stages. And then the manufacturer, the first meeting is always very rosy and nice, like the first round of the boxing match. So you have to explain to them what's new. And I think the previous speakers also told, does it have a need in today's practice? Is it better than all the current IOLs that are available in the market? Is the learning curve shorter, better post-op results? So lots of theory and explaining going on with the manufacturer, trying to make them understand what is the need, isn't it? But then in the second round, it becomes more tight actually, because that's when they start asking you questions. So they ask about the cost involved, the materials, the licensing issues, sterilities, protocols, patents. And that is when actually is something new for us as doctors we are not aware of. But I think we are working very closely with Remedio also. We've known them for more than 8 years. But they have done a brilliant thing. They try to explain to you and then how you work, and they're willing to take your ideas and then modify also. So unless you have this cordial relationship, I think you can't be cutthroat with anybody and take anything forward. So after this, then we came up with a concept that we'll have a 3-month deal. So now you have the proof of design. So it actually takes 3 months to bring it to actual practice. So what I thought of lens manufacturing and bringing it to real life was something different, because you have to have a different size cutting, even though the material is the same. And then they have their protocols of, if you make so many lenses, so many have to go through sterility check, so much of wastage is there, and only then they can give it for this is not trial, because this is for intraocular use. So there is almost a year of progress that goes behind, and all this cost is taken up by the company, because this is an IOL thing. And then that's how we came up with this thing that we'll call it the CMT Flex. So the T junctions are something that was a special design that was done. So the whole concept was, you make a sclerostomy. I'll show you a small video clipping, a 1-minute video clipping, how it works. So you just go through the sclerostomy and bring it out, and these T junctions open up. So that prevents the IOL from falling back. So there is no tucking, there is no suturing, anything required. So I wanted to make it something simple, but then we have also gone through various models. We had the first prototype, and then you have some difficulties with that. As far as IOL, I can tell you, one of the questions they'll ask me about the stretchability, or what kind of water composition that you can use to make it more elastic. At the same time, because it is an aphakic patient, we should make sure that the haptics don't rub the iris when the dilatation happens, and you also need a good dilatation. So we had to create an angle there. So these were small things, but it goes on as you learn, and then you come up with the final design. But as Suvan sir said, we had already done the patent, and then we have actually launched it today. So all these people have not just saying, just over a casual breakfast, we had the discussion, because I was inspired with his strings, and then he had gone through the entire thing. Then there are certain add-ons that you can do, because you have an instrument now, you have an idea, so you need some instruments to support it also. So that is how we came up 2 new forcepses, because these were hydrophilic materials, so we could not use the sharper forceps, so that it will bite away or you'll cause this thing. Then the third thing why you need manufacturers in this type of a thing is, yes, you'll have to tell it to the public, because you're all here for conferences. It's very difficult for doctors to go meet other doctors individually, and I think that's not possible. So you need a platform. So the first thing is maybe the local CMEs, and then you have the state conferences, and then actually officially we have launched the lens to yesterday in AIOC here in Gurgaon. So it's a win-win situation for both, because that's the only way people are going to know about it, and they're going to use about it. You can't do everything on your own. And last, yes, after you've gone through all this, then you have launched it, and then definitely this is a very, very important part, and that's what I learned from Sunny Sengupta, we did a fellowship together, and then he's been doing great in that. He's also got these lovely teaching modules. So that was something innovative he has done. So he can actually share his website where you can just sit at home and then go through all these classes, which we didn't have before, I think. Now they made it compulsory for the DMBs to attend, but that was a good thing. And then yes, before they used to say publish or perish. I think now it's slowly moving ahead, publish and flourish, so that it's a positive energy. Then everybody should start publishing and take it in a good in this thing. So yes, change is the only constant thing. So keep updating. The newer versions are going to come. Modifications of the designs are going to come. And then yes, you have to give some time away from all your other work. You have family, you have your work and everything. But then if you want to be an innovator and dedicated, there is a certain amount of time. All those previous speakers just didn't do it overnight. I think they've given up a lot of time. And be persistent, and no substitute for hard works. And don't stop until you reach your goal. You may fail once, but then keep trying and trying. That's what I can say. Thank you. Thank you, Sen, and thank you, everybody else. I'll just show you the small video of the financial aspects, even I'm still yet to learn. Can you just forward it? No, I'm just forwarding to the actual. This was my previous thing in which I was talking about iris claw lenses for aphakia and the other scleral lenses. Let's get to the point. I'm not able to. Yeah. One second. Yeah. So this is the actual lens and the actual case. So what this lens is, the remaining steps are the same as any glued or any scleral fixated lenses. The most important thing here is the 0-180 degree marking, and then you make these 23 gauge sclerostomies. So this is the new T junction that you can see in the lenses. They are totally hydrophilic material. So these are goes through a normal 2.8 cartridge that you could use in any of your normal cartridges. So there's no fancy cartridge or anything. So it's got an optic and it's got this thing. So you have these specialized grasping forceps. You make sure you just grasp the head on. That is the best way. But you can also hold the neck, because we have tried that. And then right now you should not actually pull the lens out, because that can sometimes detach it from the body. So now I'm just injecting the lens inside. You can leave the trailing haptic outside or over the iris, so that prevents it from falling in these aphakic patients. And then when you bring it outside, so the T opens up, and that's it. So that actually prevents it from going back into the sclerostomy, and it actually plugs the thing. So the same thing, I think you'll have to repeat it on the other side. Just a small animation clip of the same. You can do it head on, or you can do it at right angles. It really doesn't matter. You can actually even hold the neck. Because it's a hydrophilic material, it's very forgiving and also very tissue friendly. And then you just close the scleral flaps. So the second haptic, through that handshake technique, you just transfer the haptics, holding it head on again here. And then gently bring it out. And the only thing that matters is 0 180, and you have very good centration. You don't have to worry about centration because there's no tucking, no angulations, and 23 gauge, sir. 23 gauge. Yes, sir. So we have gone through a lot of things. We tested different things, and that's how we have come out. So this is the product that I was talking about. So I had to tell you about that also. So how we worked. Thank you.
Thank you. It was very nice, and we come to the last IJO impact on the innovations. Sabyasachi Sengupta is going to tell us. I think this has been a very innovative session. We've learned so much, and now we see how the IJO has helped us to innovate. Go ahead.
So I thought I'll bring all of this together by telling you how IJO has been involved in bringing some of these innovations to its readership. 3. Okay, so very quickly, why the IJO? Because it is open access, it is indexed in PubMed and many other indices. It has a very wide reach. It has quick review process and decisions now with Dr. Honavar's term. It is of course pro-Indian. It accepts a lot of variety of different articles like devices, techniques, etc., where your innovations actually can fall into. It is a dynamic, you have a dynamic and encouraging editor who is right here with us, and the journal recognizes the need to bring out and archive the best in Indian ophthalmology. Excuse me, next slide. It's not happening. Yeah. So this was an editorial which was published in 2019, which talks about innovations in ophthalmology and the potential power of frugal innovations. The editorial board of the Indian Journal of Ophthalmology recognizes the need to highlight native innovations and find space for them in the academic literature, and we have initiated a new section called Innovations in Ophthalmology. And we look forward to a good flood of good publications in this section. This is exactly what our editor wants to send the message out to everyone. So these are some of the examples which have been published since January 2018. I'll show you several of these. We won't go into the details. So this was in January 2018, so which talked about use and validation of mirrorless digital single light reflex camera for recording of vitreoretinal surgeries in high definition. Then this was published in August of 2018, which talked about using of chandelier assisted retroillumination for phacoemulsification in phaco-vitrectomy, a rather sort of difficult situation. If you look at the top left image, you really don't have a red glow. Then newer devices which are coming in, and then you want to actually validate them, you want to publish your results. So this was some of the initial work on Zeptorexis, which was published in September of 2018. this was quite an innovative technique which was published in November 2018, which talks about smartphone-based evaluation of the optic nerve head. Then there have been a host of publications on artificial intelligence, which there was a guest editorial, there's a review article, and now recently there is an original article all on artificial intelligence. Then there are very small sort of innovations, which this is a use of a wire lid retractor as a new use of a new use of a wire eye speculum. So you can actually evert the lid using that innovation. Then this is again published recently in May 2019, which talks about trash to treasure RedCam. So what these authors are using is all the trash which you generate in your OR, and then trying to make a retinal imaging device with that. Then of course this is something that we all know about, is the MI RedCam assisted smartphone based fundus imaging for retinopathy of prematurity. It was published in June 2019. This is again a smartphone guided wide field imaging unit for ROP, which is a do-it-yourself sort of version, again in June 2019. And this was right from the horse's mouth. So this is the simple limbal epithelial transplantation, or SLET, which was pioneered by this group, and they have actually put all of their findings together. So this is pretty much everything there is to know about SLET from the innovators themselves. Then there was a recent editorial in September 2017 on external ophthalmic videography with different tools and techniques. Very interesting. You should read it if you haven't. In the same edition, there was in the same volume issue, there was another on flexible tripod mounted video camera, an economical and effective method to record oculoplastic surgeries. So these are all innovations. I've showed you about 8 or 9. Some of them have also been rejected. But what IJO is looking to do is to highlight your innovations and bring it to the fore. Very important is to do it well, write it well, and the material. It's sometimes not only important to be very innovative, but also important to the way you present it. So we are looking for highlighting your innovations, provided they are done well. So I hope that with all of these, you will choose IJO as your journal of choice to bring your innovations into the real world. Thank you very much.
Thank you, and we have exactly 2.5 minutes. Santosh, we would like to have your comments on the session and also the way forward.
It's wonderful. Everybody did a great job. I think some of you are ignited with all these nice talks. Thank you so much. Thanks for being here.
Any questions from the audience? We have 2 minutes. Any questions? Everybody's awake, sleeping? No, they're people. Okay, so if you have no more ideas, I'm sure that everybody who's spoken today is approachable. Their emails and contacts are available, so you can always have discussion over tea and coffee, which is always better. Anything can happen over that. Okay, thank you.